The WHO guidelines for resource-limited countries like India, what do they say about breastfeeding in a baby born to HIV-positive mother? Hello friends, in this video we'll be discussing the latest exam questions from the INI-CET May 2022. So these questions are based upon the recall by you and your friends, okay? So these questions may not have the exact wordings or the exact options, but what is important for you to remember is that these are very, very important topics and many of them are, repeats direct or indirectly. So these topics are a must know for you. 80% of questions, 80 to 90% questions were, straight from the pediatrics videos. There were a couple of questions which would, need some latest recommendations or guidelines or information. But overall, the pediatrics questions were very simple, reiterating the fact that get your concepts clear, make your basics strong, and you'll be able to answer most of the questions, right? So let us discuss one by one. So which of the following is the best way to assess adequate response to ventilation during neonatal resuscitation? Is it chest rise or improvement in heart rate or change in color, or is it respiratory rate assessment? So the best way to know whether you are doing neonatal resuscitation properly or not, when you are doing neonatal resuscitation, if the baby's heart rate is less than 100 per minute or baby is having apnea or gasping, then you need to do positive pressure ventilation. And this positive pressure ventilation in neonatal resuscitation is usually done using a bag and mask. And the bag and mask is a self-inflating bag and a mask, okay? And this self-inflating bag and a mask is used in all the situations except there is a contraindication to bag and mask ventilation, which is very, very important question often asked, and that is congenital diaphragmatic hernia. You do not use bag and mask ventilation in this situation, okay? Congenital diaphragmatic hernia. Now, when you're doing bag and mask ventilation or bag and tube ventilation, the most sensitive indicator of effective ventilation, so the most sensitive or the best indicator, most sensitive indicator of effective ventilation, okay, whether you are ventilating the baby properly or not, is improvement in heart rate. So if the baby's heart rate was low and it improves, that is the earliest or the best indicator of whether you are resuscitating the baby properly or not, okay? So improvement in heart rate is most important, okay? The change in color and the other parameters come later. The most sensitive indicator is improvement in heart rate. So coming back to the question, which of the following is the best way to assess adequate response to ventilation during neonatal resuscitation? So the best answer to this is improvement in heart rate. Okay. Moving on to the next question. For a low birth weight neonate, we all know what is a low birth weight neonate, a baby whose birth weight is less than 2.5 kgs. Okay. What is the best suited in absence of mother's breast milk? Okay. So if the best for any baby is mother's breast milk, and we know why. There are so many advantages of breastfeeding for the baby, which we've discussed in the nutrition chapter in great detail, okay? Now, if mother's breast milk is not available due to any reason, okay, then what is the next best option that you can offer? So, if donor breast milk is available, that means breast milk which has been donated by other mothers. So if excessive of breast milk was there and the baby is not having so much, so nowadays the concept of breast milk bank has come up very recently, and you have breast milk banks available from where if the baby is not getting breast milk due to any reason, donor breast milk can be available. So donor breast milk is the next best option if a baby is not getting breastfeeding or even expressed breast milk, okay? So if donor's breast milk is also not available, so breast milk from any other source is not available, then you can use term formula milk or preterm formula milk for that baby, okay? Depending on whether the baby was born term or preterm. Cow's milk is not a very good option to be used for the babies, as it lacks many of the essential ingredients that the breast milk has. We've already discussed in great detail how the breast milk is different from cow's milk and what are the advantages of breast milk over cow milk, okay? So the best answer out of the given options is donor's breast milk, but of course it does come with its own set of some disadvantages, like there is a risk of transmission of infectious diseases if adequate care is not taken, okay? So that is there, and of course the availability might be a challenge for everyone, okay? Moving ahead, not useful in the emergency management of hyperkalemia. So we know the normal potassium values in children is between 3.5 to 5.5 milliequivalents per liter. Okay. Now, if the potassium level becomes more than 5.5 milliequivalents per liter, then we call it hyperkalemia. And hyperkalemia, you get a lot of ECG changes, like you get tall T waves, which are an important telltale sign of hyperkalemia in children. Okay. Now, to treat hyperkalemia in children, the emergency management includes a few things. One is we give injection calcium gluconate. You know, this injection calcium gluconate is not going to cause a decrease in potassium level, but it has a membrane stabilizing property. Now, because of hyperkalemia, the membranes, the cardiac membranes and the other muscle membranes, the membranes of the cell, their electrophysiology becomes abnormal. So, injection calcium gluconate helps in stabilizing that. So, calcium gluconate is very, very important. It will help prevent arrhythmias, which can occur due to hyperkalemia. So, injection calcium gluconate is used in management. Apart from that, injection insulin and dextrose is used. Actually, insulin sends the potassium intracellularly from the extracellular fluid so that the blood potassium level goes down. And if you give insulin alone, there is a risk of hypoglycemia. So, you give it along with dextrose. So, injection insulin and dextrose is another option that may be used. Salbutamol nebulization, okay, also helps. You know, one of the side effects of salbutamol nebulization is hypokalemia. So, salbutamol nebulization also helps in bringing down the potassium levels. Injection sodium bicarbonate also helps in decreasing the potassium levels, because again alkalosis will cause intracellular shift of potassium. Okay, so the potassium levels in the blood will come down. So, injection sodium bicarbonate. So, these are few things which are used in the acute management of hyperkalemia. Okay. So, coming back to our question, not useful in the emergency management of hyperkalemia. Salbutamol nebulization we know is useful. IV magnesium sulfate, no, that's not useful. Calcium gluconate is useful, and injection insulin and dextrose is useful. So, the best answer out of the given options is IV magnesium sulfate. Okay, I'm sure you got it correct. So, now moving on, which of the following is a X-linked dominant condition, whether it is spinal muscular atrophy, Duchenne muscular dystrophy, Rett syndrome, or ornithine transcarbamylase deficiency. So, you know, spinal muscular atrophy we know is a disorder of the anterior horn cells, where you get a central hypotonia, a floppy baby, and depending on the severity of spinal muscular atrophy, the baby may not be able to, you know, sit or stand or walk. A telltale sign of spinal muscular atrophy is tongue fasciculations, and it usually has, you know, autosomal recessive inheritance, and the gene involved is the SMN gene. Okay, so it does not have a X-linked dominant inheritance. Duchenne muscular dystrophy, again we know, is a disorder of muscles where, you know, there is pseudo hypertrophy of calf muscles is there. There is proximal muscle weakness, so the child has difficulty in climbing stairs, difficulty in getting up from sitting position, and you know, there is this Gowers sign which is positive. A less severe form of Duchenne muscular dystrophy is the Becker muscular dystrophy, and they have X-linked recessive inheritance. Okay. Rett syndrome is a condition which has X-linked dominant inheritance. We have discussed it in great detail in the behavioral disorders and also along with microcephaly. So, X-linked dominant condition where you get acquired microcephaly, and it is more common in girls. So, initially at birth the head size is normal, then there is deceleration of head growth, the baby goes on to acquire microcephaly. MECP2 gene is the most common gene involved in Rett syndrome. And there is also stereotypic hand wringing movements in Rett syndrome. Okay. So, Rett syndrome does have a X-linked dominant inheritance. OTC deficiency or ornithine transcarbamylase deficiency is a urea cycle disorder, but it usually has X-linked recessive inheritance, not X-linked dominant. So, the best answer out of the given options is Rett syndrome, which has X-linked dominant inheritance. Another disorder, important one, which has X-linked dominant inheritance is the hypophosphatemic rickets, where the petechiae gene is involved. Okay. So, again a straightforward question based on your concept of inheritance from genetics. Now, which amino acid does not need to be restricted in diet in maple syrup urine disease? So, in maple syrup urine disease, friends, as we have already discussed in the videos on inborn error of metabolism, there is a problem in the metabolism of branch chain amino acids. Okay. So, problem in the metabolism of branch chain amino acids. So, what will happen? The branch chain amino acids are going to accumulate in the body. And which are the branch chain amino acids? Leucine, isoleucine and valine. So, all these three are going to accumulate in our body. excess of them will be present and they will cause, a lot of manifestations, including neurological manifestations. So we would like the child to have a diet which is, deficient in these branch chain amino acids. So we would like to restrict leucine, isoleucine and valine. But we will not like to restrict methionine in this condition, okay, because there is no problem in the metabolism of methionine here, right? So that is the best answer out of the given options. Okay, moving ahead to the next question. What we have here is a 2-year-old male child who was admitted with recurrent bloody stools. So there is blood in stools, okay, which can be due to some bleeding diathesis, it can be due to recurrent diarrhea, infections, okay. Atopic dermatitis like rash is also there, and there are petechial spots, again indicating probable thrombocytopenia. On complete blood count, his total leukocyte count was normal, but the platelet count was 20,000 per millimeter cube. What is the next best step to establish the diagnosis? So friends, some of you also mentioned that there were small sized platelets in this child. Okay, so all these are pointers towards a disorder which is known as Wiskott-Aldrich syndrome. So Wiskott-Aldrich syndrome, you clinically recognize it by a triad. What is the triad of Wiskott-Aldrich syndrome? So the three things that are there are microthrombocytopenia. So micro means small sized platelets are there, and thrombocytopenia, that means the platelet number is also reduced. So microthrombocytopenia is there. There is atopic dermatitis, okay, atopic dermatitis. Okay, so skin rashes are there, right? And there is also recurrent infections. So there is some form of immunodeficiency which is also there, okay. So the given case scenario typically is how the children with Wiskott-Aldrich syndrome are going to present. Now, Wiskott-Aldrich syndrome is an X-linked recessive condition. It has got X-linked inheritance, okay. So the gene, the WAS gene, Wiskott-Aldrich syndrome gene, is present on the short arm of chromosome X. So it is present on chromosome XP11, okay. And this encodes the WASP protein, the WASP protein, okay. The WASP protein is encoded by this gene, and this WASP protein is present on the non-erythrocytic hematopoietic stem cells, okay. Now, if there is a mutation in this WAS gene and there is abnormality of the WASP protein, then we get this Wiskott-Aldrich syndrome. Now, in Wiskott-Aldrich syndrome, clinically we know we will get recurrent infections, thrombocytopenia, so bleeding manifestations and skin manifestations in the form of atopic dermatitis like rash, right? And on investigation, what will you get in Wiskott-Aldrich syndrome? So on investigation, there will be thrombocytopenia like we saw in this child, okay. Thrombocytopenia, so the bleeding time may be prolonged, so there is thrombocytopenia, and the platelets are going to be small in size. So small sized platelets, okay, small sized platelets. So what happens to the immunoglobulin level here? So there are recurrent infections, we said. So immunoglobulin level, the IgM level is low in Wiskott-Aldrich syndrome. You can remember the reverse of M is W. So IgM is low in Wiskott-Aldrich syndrome, and IgE and IgA are elevated in Wiskott-Aldrich syndrome, okay, elevated. So remember, E and A come in the word elevated. So IgE and A levels may be elevated and IgM levels are low usually in Wiskott-Aldrich syndrome, okay. Now, how do you manage these children? Now, Wiskott-Aldrich syndrome usually has a very poor prognosis, okay. And you can manage these children by, giving intravenous immunoglobulins may be given at regular intervals. You might have to give prophylaxis for pneumocystis carinii pneumonia in the form of cotrimoxazole. So pneumocystis carinii prophylaxis or prophylaxis against pneumocystis cerevisiae in the form of cotrimoxazole needs to be given. Okay, so prophylaxis should be given, right? And you have to treat whenever infections are occurring. You have to treat them vigorously. Sometimes even splenectomy may be required, okay. Prophylactic antibiotic treatment may sometimes be required if the child is having recurrent severe life-threatening infections, and the definitive treatment is by hematopoietic stem cell transplant, okay. Hematopoietic stem cell transplant. Now the diagnostic investigation. So we said there are some findings on investigations like thrombocytopenia, small platelets, and the problem in the immunoglobulin level. But if you talk about the diagnostic investigation, it is the genetic test. So you can demonstrate the mutation or the pathogenic variation in the WAS gene. So WAS gene sequencing can be done by Sanger sequencing, okay, WAS gene sequencing can be done, or you can do WAS protein expression study. That can be done by flow cytometry. Okay. So WASP protein expression can be seen by flow cytometry. So that is the definitive test for diagnosis. Okay. And it is obviously more common in boys, it being a X-linked recessive disorder. Now moving back to our question. So in the given scenario where you have a 2-year-old male child who was admitted with recurrent bloody stools, and where we are suspecting Viscott-Aldrich syndrome, the best test to arrive at a diagnosis, anti-platelet antibody assessment is not going to help, because it is not, the problem here is not the anti-platelet antibodies like you get in ITP. Screening for WASP expression by flow cytometry, yes, that will help you give clue whether this is Viscott-Aldrich syndrome. Okay. Bone marrow aspiration is not going to help you arrive to a etiological diagnosis. However, it may help in excluding other disorders like an underlying lymphoreticular malignancy. And by the way, the risk of lymphoreticular malignancy also is increased in children with Viscott-Aldrich syndrome. Okay. LFT and RFT, again the liver function and the kidney function test will provide non-specific clues only, will not help you reach towards a diagnosis of Viscott-Aldrich syndrome. Okay. Moving ahead to the next question. Management of a baby born to a HIV positive mother. Now friends, there is some confusion in this question. I am not sure what exactly was the question given, because I have got different versions from different students. But if such a scenario comes, let us see how do we answer it. So management of a baby born to a HIV positive mother who is to be exclusively on top feed includes which of the following? Now what should we do? Baby is tested for HIV and given zidovudin only if the baby comes out to be positive? No. All babies born to HIV positive mother are started on zidovudin or nevirapine at birth. Okay. Irrespective of their HIV positivity is there or not, breastfeeding is done or not. Okay. Babies started on zidovudin even before the result of HIV testing is available? Yes. You have to start the baby either on nevirapine or zidovudin or both before the result of HIV testing is available. Okay. If replacement feeding is being given, that means if breastfeeding is not given, no prophylaxis required. Again, this is also not true, because transmission of virus can happen during pregnancy, it can happen during labor, it can happen in the peripartum period, not necessarily through breastfeeding. So even if replacement feeding is given, antiretroviral prophylaxis is required for the baby to prevent the maternal to child transmission of HIV. Replacement feed and zidovudin is to be given for 6 months even if the child is HIV negative? No. If we are sure that the baby is HIV negative, then zidovudin or nevirapine need not be given further, and for 6 months it is not recommended. Okay. So let us see what are the recommendations then. Now these are the recommendations of the latest recommendations which came in 2021-22 only from the United States. Okay. So if there is low risk of transmission of HIV, that means the mothers who have received antiretroviral therapy through their pregnancy and they have very low viral loads, the HIV RNA copies are less than 50 copies per ml. In those babies, just zidovudin alone or maybe nevirapine alone may be given for 4 weeks. But in the mothers where high risk of perinatal HIV transmission is there, like if the mother did not receive antepartum antiretroviral drugs, or the drugs were given only during the labor, or the mother did receive antiretroviral drugs but HIV RNA copies were too many in number, high viral load was there, okay, or the mother who acquired acute primary infection of HIV during pregnancy or breastfeeding. So in these situations, we consider it to be high risk, and presumptive HIV treatment using 3 drugs like zidovudin, lamivudin and nevirapine is recommended from birth up to 6 weeks, or till the time that you have ruled out whether the baby is HIV infected or not. So that is what the latest, guidelines say from abroad. And there, in United States and where developed countries, breastfeeding is not recommended, because breastfeeding does carry at least some risk of transmission of HIV to the baby. But in resource limited countries like India, that is not so. We'll be coming to what are the recommendations in India. But apart from that, we also need to know that, antiretroviral therapy should be initiated without waiting for the result of HIV for all babies born to HIV positive mothers at birth. Okay. So you need to start either zidovudin or nevirapine or both. However, specimen for confirmatory testing should be obtained prior to ART testing. And the NAT testing, the nuclear acid amplification testing, is a screening test. You should not rely on that to stop the treatment. You should get a PCR done. Okay. Antiretroviral drugs should be initiated as soon as possible after birth, preferably within 6 hours of childbirth. Okay. Now, The WHO guidelines for resource-limited countries like India, what do they say about breastfeeding in a baby born to HIV-positive mother? Mothers living with HIV should breastfeed for at least 12 months. So, exclusive breastfeeding for 6 months and breastfeeding may be continued up to 12 months or even longer, like in general population, provided the mother is getting proper antiretroviral treatment. Okay? Mother known to be living with HIV who decides to stop breastfeeding should not do it abruptly. It should be done over 1 month or so. Okay? And infants who have been receiving antiretroviral drug prophylaxis should continue that for 1 week after breastfeeding. Okay? And for mother, the antiretroviral therapy needs to be continued. It is not just that during breastfeeding you are giving and then stopping it. Okay? So that is the current recommendation for baby born to HIV positive mother. Okay? And cesarean section as such is not recommended just for prevention of transmission of HIV to baby, unless it is a very high risk situation and the mother has really high viral loads, then one may consider it on a case to case basis. Moving ahead to our next question, we have a 1-year-old boy who is brought to you for vaccination. He has only received 1 shot of DPT at 6 weeks. What should you do now? So this is basically a question on catch-up immunization. What should you do? No need for giving DPT now, or give second dose of DPT shot, or restart DPT regime from the first dose again, or start DT regime. So friends, I am sure you know the answer to this question. So you have to give the second dose of DPT. So because there is an immune memory, if the baby has received any dose of a vaccine, we count that dose, and whenever the child comes, we start from that, we count that dose and we start from the next dose. So as this baby has already received first dose of DPT, we are going to start with the second dose of DPT. So start from the point of interruption. Okay. So start from the point of interruption. So you need not start the immunization schedule from the scratch again. But you have to see whether the child is eligible to receive those vaccines at that dose or not. That means beyond 1 year, if an unimmunized child comes beyond 1 year, we cannot give BCG, we cannot give pentavalent vaccine according to National Immunization Schedule of India, and we cannot give, rotavirus vaccine. But we can give DPT vaccine can be given, okay? Measles or MR vaccine can be given, okay? But beyond 7 years of age, even DPT vaccine is not given. You need to give the small d wala vaccine. You need to give DTaP beyond 7 years. Okay? Right? So that is how we have to decide the catch-up immunization. Okay? Moving ahead to the next question. Which of the following is the recommended dose for HPV vaccination in girls aged 9 to 14 according to the WHO SAGE protocol? So the WHO strategic group which provides advice on immunization, it has given a latest recommendation in April 2022. So prior to that also, 2 doses of HPV vaccination were recommended for girls 9 to 14 years of age. Now they have accumulated evidence and have seen in various studies that giving 1 dose or 2 doses of HPV vaccine gives equivalent protection. So they are telling now that either 1 or 2 doses of HPV vaccine may be given to the 9 to 14 year age group of girls. Okay. So the best answer in the given scenario is 1 or 2 doses. So they have not made it a recommendation till now that only 1 dose needs to be given. But the best answer is either 1 or 2 doses of HPV vaccination may be given in the 9 to 14 years age group. Okay. So moving on to our next question. Which of the following is not useful in the management of sickle cell anemia? So we know in sickle cell anemia, hydroxyurea has been used since ages, and it acts by multiple mechanisms, including it elevates the HbF level, which will decrease the relative concentration of sickle cell hemoglobin and which will reduce the polymerization of HbS and the clinical manifestations. Some of the other drugs which have been, recently approved for the treatment of sickle cell disease. So hydroxyurea will be discussing in more detail about the mechanisms by which it acts. The other drugs which have been approved for sickle cell disease but are not available so readily, one is voxelotor. So this voxelotor, remember, OX is there in its name. So it acts by increasing the oxygen affinity of HbS. So it increases the oxygen affinity of the sickle hemoglobin. So what will happen? We know only when the sickle hemoglobin gets reduced, it polymerizes and it causes the occlusion and the crisis and the clinical manifestations. So because it increases the oxygen affinity of HbS, so it decreases the risk of vaso-occlusive crisis and it, decreases the risk of occlusion of various blood vessels and the clinical manifestations. L-glutamine, it acts by inhibiting the P-selectin. So by inhibiting the p-selectin, it helps in decreasing the adhesion of the RBCs and WBCs to the endothelium, and again thus it helps in decreasing the clinical manifestations. So we saw this hydroxyurea is useful, voxelotor may be used though not readily available, and even L-glutamine may be useful in the treatment of sickle cell anemia. Apart from that, maintaining hydration is very important, okay, and the management of painful crisis with the help of NSAIDs, and sometimes the pain is so severe even morphine may be required, and treatment of infections, okay. So this is how you manage sickle cell anemia. Hydroxyurea, we said, it has an anti-sickling effect by induction of fetal hemoglobin. The HbF level is going to rise, so the relative concentration of HbS is going to decrease and manifestations decrease. Apart from that, it also improves RBC hydration, it reduces the leukocyte adhesion, and it reduces pro-inflammatory markers, and it acts as nitric oxide donor, promoting vasodilatation. Okay. Now the drug out of these which is not useful in the management of sickle cell disease is the bebtelovimab, a recent drug which is used in the management of COVID-19, which is rather recommended in the management of COVID-19. So a word about this bebtelovimab. It is a new monoclonal antibody for the treatment of COVID-19 that is effective against the spike protein, okay, that acts against the spike protein of the SARS-CoV-2 virus, and it is also effective against the Omicron variant of the SARS-CoV-2, okay. So this bebtelovimab is approved for the treatment of mild to moderate COVID-19 infection in adults and children more than 12 years of age with a positive COVID test who are at high risk of progression to severe illness, hospitalization or death, okay. But in situations where no other treatment may be given to them or may be available, okay. So this is a new drug, the name of which at least you must remember, right. Moving ahead to the next question, ACTH or adrenocorticotropic hormone is used in the treatment of which of the following, whether it is juvenile myoclonic epilepsy or Rolandic epilepsy, West syndrome or Lennox-Gastaut syndrome. Now juvenile myoclonic epilepsy, we know the drug of choice is usually valproate, okay. Rolandic epilepsy is also known as benign epilepsy with centrotemporal spikes, and you usually get focal or partial seizures in Rolandic epilepsy, and it has a good prognosis, and usually carbamazepine or oxcarbazepine is used in the management, okay. West syndrome is a condition where there is a triad of infantile spasms or salam attacks like this, okay. So there are infantile spasms, okay, there is intellectual disability, global developmental delay and intellectual disability, and if you do a EEG, there is a chaotic pattern which is known as Hips arrhythmia. So West syndrome is a condition where you get a triad of these three things: infantile spasms, intellectual disability and Hips arrhythmia, and the treatment of choice for West syndrome is injection ACTH, adrenocorticotropic hormone. So if injection ACTH is not available or there are feasibility issues, people have also tried corticosteroids for treatment, okay. And if a child with infantile spasms also has tuberous sclerosis, then the drug of choice becomes vigabatrin, okay. Now Lennox-Gastaut syndrome is a condition where you have multiple seizure types of different semiology. There may be absence attacks, there may be myoclonic jerks, there may be tonic-clonic movements. So multiple seizure types which are refractory to treatment. So usually Lennox-Gastaut syndrome requires a combination of anti-epileptics to act, and sometimes other measures like ketogenic diet and all may also be required. So the best answer out of the given options, ACTH is used in the treatment of is West syndrome, okay. Again, we have discussed it in our videos. Now, which of the following is associated with congenital absence of vas deferens and seminal vesicle? In tuberous sclerosis, we know it is a neurocutaneous disorder where you get, some skin manifestations like adenoma sebaceum, ash leaf macule, shagreen patches, and you can get some hematomas in various places, okay. And you can get some cardiac involvement can be there, some eye involvement can be there, some kidney tumors can be there. But this congenital absence of vas deferens and seminal vesicles is not commonly seen. In cystic fibrosis, there may be development of Wolffian duct structures are not proper. Okay, so there may be abnormal development or agenesis of the Wolffian duct structures. Okay, and the males with cystic fibrosis mostly have azoospermia because of that. So you can get congenital absence of vas deferens and seminal vesicle in cystic fibrosis. Kallmann syndrome is a condition where you get hypogonadotrophic hypogonadism. So there is decreased LH and FSH levels because of which the gonads do not develop properly, but there is no congenital absence of vas deferens or seminal vesicle. There is no structural defect as such in Kallmann syndrome. Testicular feminizing syndrome, again we know, is a condition which is also known as androgen insensitivity syndrome, where again the androgen hormones, the testosterone, is not able to act because of the resistance at the level of receptors. But there is no congenital absence of vas difference or seminal vesicles here, though the external genitalia may have a female-like appearance, though the karyotype is XY. So the best answer out of the given options is cystic fibrosis. Okay. Moving ahead to our next question, what we have here is a 4-year-old male child with body weight of 15 kgs and height of 100 cm who is admitted with renal failure. Okay. His blood urea was 100 mg per dl and serum creatinine was 1 mg per dl. What is the closest calculated estimated GFR in this patient? So we know in such patients with kidney dysfunction, we can use something known as Schwartz formula to calculate the estimated GFR. So Schwartz formula can be used to know the estimated GFR or glomerular filtration rate in children, and Schwartz formula is basically a K, which is a constant, into the height of the child in centimeters divided by the serum creatinine in milligram per dl. Okay. So the value of the constant in children is usually taken as 0.413. Okay, 0.41 you can remember. Okay, or 0.4. So as per the Schwartz formula, in this case, how much will be the estimated GFR? Estimated GFR in this case would be, so in this case the constant we put as 0.4, the height is 100 centimeters given in this question, and the creatinine value is given as 1 mg per dl. So the estimated GFR comes to be 40. So 40, and the unit of GFR we know is milliliter per minute per 1.73 meter square. Okay, so that is the estimated GFR in this case. Very easily. Again, we have discussed it in our videos, Schwartz formula, and also the staging of acute kidney injury you can look up from the videos on pediatric nephrology. Moving ahead, tongue fasciculations are a feature of which of the following? So Myasthenia gravis, we know there is fatigable muscle weakness. Okay, that means in the morning there is no muscle weakness. By the end of the day, the child begins to have muscle weakness. The classic example is seen in the extraocular muscles. In the morning, the eyes are wide open, but as the day progresses, there is ptosis and the child is unable to open the eyes fully. So Myasthenia gravis, there is a fatigable weakness. Okay. Spinal muscular atrophy, we mentioned, is a condition where anterior horn cells are involved. There is a floppy child, there is central hypotonia, and tongue fasciculations are seen. Okay. So that means if you ask the child to open the mouth and you don't ask to protrude the tongue lies inside the mouth and you can see some abnormal quivering movements on the tongue. It is easily observable on the tongue because there is very little subcutaneous tissue, almost no subcutaneous tissue in the tongue, and you can see the muscles directly. So the muscle fasciculations are very well visible in the tongue. Okay. Guillain-Barré syndrome, again, you have, acute flaccid paralysis, and there is absent deep tendon reflexes, but you usually do not see muscle fasciculations. Duchenne muscular dystrophy, again you have pseudo hypertrophy of calf muscles can be there. The tongue may also be enlarged, and there is cardiac involvement also. Proximal muscle weakness is there, but fasciculations are usually, tongue fasciculations are not so prominent feature. Okay. So spinal muscular atrophy is the best answer out of the given options where the SMN gene deletion is there. Okay. So moving on to the last question that we have here, a 5-year-old male, and this topic has been repeated so many times in the AIMS and INI-CET exams. So 5-year-old male was admitted with complaints of fatigue and joint pains. On examination, a rash was found on her hands. You can see the rash is there on the knuckles and on the proximal and distal interphalangeal joints. So this papular rash is something known as Gottron papules, and you can also sometimes get a violaceous hue around the eyes, which is known as heliotrope rash. So this heliotrope rash and Gottron papules are classic features of a condition known as juvenile dermatomyositis. In this condition, again, there is proximal muscle weakness, which is usually, it may be asymmetric. Okay, there is proximal muscle weakness, so you can get, there is evidence of muscle degeneration, muscle involvement, so muscle enzymes like CPK and SGOT may be elevated. Okay, so on electromyography, EMG, you can get some muscle changes. On imaging of the muscles, again, you can get abnormalities. Muscle biopsy can also show abnormalities here. So juvenile dermatomyositis is another condition which has been often asked, and we need to be aware about it. Okay. So these, friends, were the important topics or questions that have been asked recently in the INI-CET May 2022 exams. So these are very important topics for you, and do not forget to revise these topics before the next upcoming exams, and be very, very sure whenever you are studying any topic, don't just go and try to mug up the answer for the MCQ, but try to prepare that topic as a whole, because very often we see that from the same topic you get different types of questions in different exams, because the important topics remain important for most of the exams. There may sometimes be 1 or 2 stray questions, but that is not going to decide, whether you get your dream branch or not. It is the majority of questions which, on them, no mistake is permissible. So work hard, study hard, make sure that you've covered at least the last 3 years of INI-CET and the NEET pattern questions before you appear for your next exams. All the very best, friends. I'm sure you will achieve all that you have ever dreamt of. God bless you. Thank you.